Yeah, hey friends, I will start with the MCQs. So the first MCQ is which of the following drugs is a vasodilator of the inner ear? I will repeat, which of the following drugs is a vasodilator of the inner ear? The options are nicotine, beta-histine, antihistamines or serotonin. So I will repeat once again. The question is which of the following drugs is a vasodilator of the inner ear? And the options are nicotine, beta-histine, antihistamines or serotonin. So anyone would like to answer this? Which of the following is a vasodilator of the inner ear? Nicotine, beta-histine, antihistamines or serotonin? So the answer here is, if no one wants to tell, the answer here is beta-histine. Why is beta-histine is the only, basically it's a vasodilator of the inner ear which we use in many diseases, as you all know. So beta-histine is a vasodilator of the inner ear, and what it does, it improves the microvascular circulation in the stria vascularis of the cornea and inhibiting vestibular nuclei. No, it's not nicotine. The answer here is beta-histine is a vasodilator of the beta-histine is a vasodilator of the inner ear. It improves microvascular circulation in the stria vascularis of the cornea and it inhibits vestibular nuclear activity. So next question we have, which is the only glycogen storage disease that is also liposomal storage disease? And the options are von Gierke disease, Pompeius disease, McArdle's disease or Corey's disease. I'll repeat once again, which is the only glycogen storage disease that is also liposomal storage disorder? Von Gierke, Pompeius, McArdle's or Corey's disease. Anyone wants to try this? Yeah, the answer here is B, that is Pompeius disease is also a glycogen storage as well as a liposomal storage disorder. And what happens here, the small amount of glycogen is degraded by the liposomal enzyme which is also known as acid maltase. So you have to remember this. So only glycogen disorder which is also liposomal storage disorder is Pompeius disease. Next question we have, given below is the histological section of a thyroid gland. Identify the structure marked as S. So I cannot show you the. Basically it's C cells or the parafollicular cells of the thyroid gland. So I cannot show you this question. So that's next question we have. 34-year-old G3P2L2 woman presents to the ER with hypotension, tachycardia and severe abdominal pain. On examination, fetal parts are palpable in the abdomen. USG abdomen reveals a large uterine wall defect. What is the most common of this condition? I will repeat once again. It's a 34-year-old G3P2L2 presents to the ER with hypotension, tachycardia, severe abdominal pain. On examination, fetal parts are palpable in the abdomen. USG will reveal a uterine wall defect. It's a large uterine wall defect. What is the most common cause of this condition? And the options are C-section start dehiscence, obstructed labor, blunt abdominal trauma or prolonged induction of labor. Anyone wants to try this? I will repeat the options. It's a C-section scar dehiscence, obstructed labor or blunt abdominal trauma, or it's a prolonged induced induction of labor. So yeah, if anyone wants to try this. Okay, the answer here is, at least try. Okay. The answer is A, that is it's a C-section scar dehiscence, because whatever you are telling, that is tachycardia, severe abdominal pain, and fetal parts are all palpable, that is okay. And it's a large uterine wall defect. Basically it goes towards uterine rupture. Yeah. It goes towards uterine rupture, and the most common cause is scar dehiscence due to the previous LSCS was done. Yeah. So that's the answer. Other causes of uterine rupture are prolonged induction, obstructed labor, blunt abdominal trauma, rupture of hematuria, rupture of pyometria. So basically, how do you manage uterine rupture? First is an immediate LSCS, and upon the extent you do a hysterectomy. So yeah, you got hypotension, tachycardia, severe abdominal pain, USG, large uterine wall defects. It goes towards the uterine rupture, and that too it is a C-section scar dehiscence, most common cause. Next question we have, identified the following. Okay, it's image based, I cannot tell. Next, patient comes to you with fever and abdominal pain, presented to the emergency. On examination, you note a mucopurulent vaginal discharge and cervical motion tenderness. You suspected she has PID. So which of this is not included in the criteria to diagnose the condition? I will repeat. It's a patient with fever, abdominal pain, and you note mucopollulant vaginal discharge and cervical motion tenderness. You suspect that she has a PID. Which of the following condition is not included in the criteria to diagnose this condition? It's a oral temperature greater than 38.3, cervical motion tenderness, mucopollulant vaginal discharge, or bilateral abdominal pain. So yeah, which of the following not included in the criteria to diagnose PID? Basically what they are asking is, it's oral temperature greater than 38.3, cervical motion tenderness, and mucopollulant vaginal discharge, or it's a bilateral abdominal pain. So anyone can try. No, which is not a criteria for PID. Okay, I will tell the answer here. The answer here is D. That is, bilateral abdominal pain is not considered to be a criteria for PID. It's not included here. It's not included, and the definitive criteria is, you all know, it's a biopsy, endometritis on biopsy, and TVS or MRI evidence, laparoscopic evidence, and minimum criteria we have, it's a lower abdominal tenderness, adnexal tenderness, cervical motion tenderness, and additional what I told, that is oral temperature greater than 38.3 degrees Celsius, mucopollulant or cervical or vaginal discharge. There is CRP and ESR. So basically, abdominal pain is not considered for the criteria for PID. Next we have, what is the most common mutation identified in patients with autosomal dominant hereditary spherocytosis? And the options are band 3, alpha spectrin, ankyrin, or beta spectrin. So what is the most common mutation identified in patients with autosomal dominant hereditary spherocytosis? Band 3, alpha spectrin, ankyrin, or beta spectrin? Yeah, if anyone wants to try this. Most common mutation in autosomal dominant hereditary spherocytosis. Okay, the answer here is, no one wants. Okay, the answer is ankyrin. This we all, even though we should know, all know what. It's a mutation of the gene coding for ankyrin, and the most common cause of autosomal dominant hereditary spherocytosis. So autosomal dominant is ankyrin, that is the most common. Band 3 and beta spectrin is also there. And for autosomal, I think that, yeah, it's okay, I'm there. Next question we have, which of the following chemotherapy regimen is used for treating patients with rectal carcinoma? And the options are Folfos regimen, ABVD regimen, RCHOP regimen, or MVSC regimen. So which of the following chemotherapy regimen is used for treating patients with rectal carcinoma? Folfos, ABVD, RCHOP, or MVSC? You have to remember this, there is no choice. So yeah, the answer here is, okay, the answer here is A, that is, the Folfos regimen is used for the chemotherapy patients with rectal carcinoma. And what is Folfos? It's a 5-fluorouracil based regimen with leucovorin or oxaliplatin. Okay, so it reduces the recurrence and improves the survival rate in colorectal carcinoma. So yeah, see, ABVD regimen, what they have given here is for Hodgkin lymphoma. And whereas RCHOP regimen they have given is for non-Hodgkin, and MVSC regimen is for basically advanced bladder carcinoma. So rectal carcinoma, we have to remember it's Folfos regimen, that is 5-fluorouracil based regimen with leucovorin and oxaliplatin. So ABVD Hodgkin, RCHOP non-Hodgkin, MVSC bladder carcinoma. Next we have a 73-year-old diabetic man is brought to the emergency with altered sensorium. He is dehydrated and his blood glucose is 550 mg per dl. Hyperosmolar hyperglycemic state is suspected. Which of the given formula can correctly evaluate his serum osmolality? So basically you have to know the formula. If you know, it's the right answer. So yeah, the options are 2 into sodium plus BUN, that is bun by 18 plus glucose by 2.8, and 2 into sodium plus glucose by 18 plus bun by 2.8, or 3 into sodium plus bun by 19 plus glucose by 2.8, or 3 into sodium plus glucose by 9 plus bun by 2.8. So basically you have to know the formula, you cannot just go with this question. So yeah, the formula for this is, it's osmolality, and it's basically, the question is of biochemistry, and you have to know, in biochemistry you have to remember the formulas. So yeah, the correct formula here is 2 into sodium plus glucose by 18 plus bun by 2.8. So you don't have any choice here, you have to remember the formula here, serum osmolality formula for this. Okay, next question we have, A 17-year-old boy presents to you with painless hematuria. He has a history to travel to Kenya. Urine microscopy revealed the findings shown below. What is the drug of choice for this condition? So basically they have given an image here. I will just tell you what is the image showing. It shows the egg of Schistosomia hematobium. And the diagnosis is schistosomiasis. So what they are asking, what is the drug of choice for schistosomiasis? Albendazole, mebendazole, praziquantel or tritlabendazole. So anyone wants to try this at least. What is the drug of choice for schistosomiasis? Options are albendazole, mebendazole, praziquantel or tritlabendazole. So if anyone wants to answer. Okay, I will tell you. The answer here is praziquantel. So praziquantel is the drug of choice for schistosomiasis. So what we give a oral dose of 40 mg per kg, or it's a 3 dose of 20 mg per kg each, given 4 to 6 hours apart, generally whatever it is, but we have to remember what? We have to remember praziquantel is the drug of choice for schistosomiasis. Next question we have, it's also image based. Okay, the question here is 28-year-old woman is there who visits a gynecologist with complaints of irregular and infrequent menstrual cycles. She is also upset that she has gained 12 kg over the past few months. Her face appears as shown in the image below. Her blood BP is 144/98 and she has multiple striae over her abdomen. So which of the following investigations would you advise to this patient? So basically the image also they have given, it's a moon phases. Now you know what is a moon phases, you can tell what your diagnosis. So I no need to tell all that. I'll just repeat if you want. It's a 28-year-old woman, irregular, infrequent menstrual cycles. She is upset. She gained 12 kg over the past few months. Her face appears to be as shown in the image below. BP is 144/98 and she has multiple striae over her abdomen. Basically the image is showing it's a Cushing syndrome. I couldn't tell already. It's a moon phase basically. So yeah, it's a Cushing syndrome. It's a case of Cushing syndrome. So what they are asking here is which of the following investigations should you advise to this patient? So the options are Cauchy-Thrombin stimulation test, midnight, serum cortisol measurement, then serum testosterone levels and abdominal USG, or serum LH to FSH ratio. So yeah, if you can answer this, what is the treatment? No, it's what is the investigation for Cushing syndrome? Cauchy-Thrombin stimulation test, midnight serum cortisol, serum testosterone level and abdominal USG, or the last one is the serum LH to FSH ratio. I think today no one is active. Okay, I will only tell the answer. So yeah, it's midnight serum cortisol measurement. Am I audible now? Yeah, it's audible. Yeah, the answer is midnight serum cortisol measurement is the right answer. Because it's a Cushing syndrome and you diagnose with that only. It's a single midnight serum cortisol level, because in Cushing syndrome, basically what happens is it's a hypercortisolism. Basically hypercortisol is present, that's why. So yeah, the options you see, Cauchy-Thrombin stimulation test and all that. Cauchy-Thrombin stimulation test is used for diagnosis of Addison disease, whereas CND, that is used for polycystic ovarian disease. So basically the answer here is midnight serum cortisol measurement for Cushing syndrome. Others are for other tests, so no one to remember that, only you need to remember this. Next question we have, it's for a membrane permeable substance. The intercellular concentration is 10 units and extracellular concentration is 5 units. If the intercellular concentration, surface area of the membrane and thickness of the membrane are doubled and the EC remains the same, what will be the net effect on diffusion? So it's a biochemistry, I don't know if you remember something or not. And what will be the net effect on diffusion? And the options are diffusion become 2h, 3h, 1/2h or 1/3h. So here you have to remember the formula. So you cannot tell just like that. I also don't remember this. The formula is J is equal to minus dA by AC by AH. It's of no use actually. Why they give this? Okay, the answer is 3h. I think no need to discuss this. Okay, next question we have, which of the following is not an indication for mechanical ventilation? I think this you can answer. The options are arterial oxygen tension less than 50 mmHg, arterial CO2 tension less than 50 mmHg, tidal volume less than 5 ml per kg or vital capacity less than 15 ml per kg. So I repeat, the question is, which of the following is not an indication for mechanical ventilation? It's arterial oxygen tension less than 50, arterial CO2 tension less than 50 mmHg, or tidal volume less than 5 ml per kg, or vital capacity less than 15 ml per kg. So anyone wants to try at least? I am not getting any answers from anyone. Okay, the answer is B, that is the arterial CO2 less than 50 mmHg is the right answer, which is not an indication for mechanical ventilation. Others like arterial oxygen tension less than 50 mmHg, or it's a tidal volume less than 5 ml per kg, or vital capacity less than 15 ml per kg are basically indication of mechanical ventilation. So it's an anesthesia question and I have to remember this because I cannot help. Basically you have to remember why arterial oxygen and all that is. Next question, we have a girl waits the entire hostel dormitory screaming about a snake in the bathroom. The matron rushes in and sees her pointing at a rope. Which of the following best describe this? Options are illusion, hallucination, delusion, pseudo-hallucination. So it's an easy one, I think anyone can tell. See, a girl is there who sees in the bathroom, she sees a snake, but when you go to the bathroom, you doesn't see any snake, it's a rope. So which of the following best describes this? It's a illusion, hallucination, delusion, or pseudo-hallucination. I think I'm going to try this at least. Basically, it's a sensory stimulus, psychiatric question, if anyone can try. Okay, again no answer I'm getting. Okay, yeah. So the answer here is it's a illusion. Illusion because she is mistaken that it's a snake. So it's a sensory stimulus. So it's a false. Delusion is false belief. Hallucination is absence of any external stimuli, and illusion is misinterpretation. So yeah, the answer here is illusion. Because if delusion was there, it will be a belief that the person is a snake god. And if it's a hallucination, there is nothing in front of you, but you can see a snake. And illusion is there is a rope in front of you, but you see a snake. So the answer here is illusion. Yeah. Okay, next we have a 35-year-old man presents with complaints of constipation, abdominal cramps, and tingling in the extremities. His blood work shows a lead level of 50 microgram per dl. What is the antidote of choice for this patient? Okay, I will tell you again. It's a 35-year-old and presents with complaints of constipation, abdominal cramp, and tingling in the extremities. And what you see, it's a lead level. Lead level is that is the 50 microgram per dl. What is basically it's a lead poisoning. What is the antidote for this in short? So the options are BAL, calcium EDTA, penicillamine, or desferrioxamine. So anyone? It's BAL, calcium EDTA, penicillamine, or desferrioxamine. So what is the antidote for lead poisoning? Okay, I think anyone? Okay, I will tell the answer. The calcium EDTA is the drug of choice or the antidote for lead poisoning, and also DMSA. DMSA is Satsimer. It is also antidote for lead poisoning. So you can give IV or IM calcium EDTA is given along with dimercaprol, which redistributes and lead to the brain and increases the risk of leading to encephalopathy and all that. So basically you have to remember it's a calcium EDTA and DMSA, which is the antidote for lead poisoning. Next we have a patient with fever and hemolytic anemia develops characteristic purview on warts 1 month later. What is the causative organism for this disease? Bartonella henselae, Bartonella quinta, Bartonella bacilliformis, Bartonella australis. So yeah, I repeat, it's a patient with fever and hemolytic anemia develops characteristic purview in warts 1 month later. So what is the causative? It's Bartonella henselae, Bartonella quintana, Bartonella bacilliformis, or Bartonella australis. Anyone can answer this? Okay, the answer here is Bartonella bacilliformis. Basically what they have told, see fever, hemolytic anemia, and purview and warts. So if you see a purview and warts, It's a characteristic of Bartonella bacilliformis. And yeah, what they have told it's a fever, hemolytic anemia followed by verruga parua lesions, that is what it told, Peruvian warts, suggestive of Oroya fever, and it is caused by Bartonella bacilliformis. And the vector here is sandfly. So next question we have, an 8-year-old child presented with right-sided proptosis. Biopsy of the orbital mass was done and histopathological examination revealed this picture. What is the most likely diagnosis? So I will tell what is the pathology given here. Because if see the histopathology they have given, it's an elongated to round spindle cells with features of skeletal muscle at different stages of maturation with highly eosinophilic cytoplasm and hyperchromatic nuclei. Basically with this also you can tell, or otherwise you can tell by the history. It's an 8-year-old child, right-sided proptosis, biopsy of the orbital mass was done. What is the most likely diagnosis? Retinoblastoma, metastasis from neuroblastoma, rhabdomyosarcoma or hemangiosarcoma. Anyone? Because you have to remember this pathology. It's an elongated to rounded spindle cells, features of skeletal muscle at different stages of maturation, highly eosinophilic cytoplasm and hyperchromatic nuclei. And this is suggestive of what? Okay, at least guess, anyone can guess at least. Okay, the answer here is C, that is rhabdomyosarcoma, because whatever they have given pathological, it suggests rhabdomyosarcoma. And the treatment for rhabdomyosarcoma, as you all know, it's a chemotherapy because it's a cancer. So chemotherapy and radiotherapy, and what we give, cyclophosphamide, vincristine, antimycin D. So yeah, it's a rhabdomyosarcoma and it's the most common soft tissue sarcoma of child. Yeah, rhabdomyosarcoma, and it's the most common soft tissue sarcoma of the child. That is 7 to years. Next we have a 6'5" man undergoing routine physical examination was found to have an early diastolic murmur. His family pedigree chart is given below. Identify the mode of inheritance of this condition. See again, it's a pedigree chart given, I cannot tell. Okay, just tell me in which condition you will find an early diastolic murmur, and it's a hereditary condition. A hereditary condition with early diastolic murmur. Anyone can tell? Okay, just tell me the diagnosis. See, it's a autosomal dominant disease, and it's a hereditary autosomal dominant, and he has a diastolic murmur. So now if anyone can tell, autosomal dominant and diastolic murmur. Okay, the diagnosis here is Malfoy syndrome, because you see in CVS also. In Malfoy syndrome, you see all that. You have the decreased upper to lower segment ratio with long arms, hands and fingers, deformities of the chest, CVS mitral valve prolapse, you can see that. This MR, you can see that. So basically, it's a case of Malfoy syndrome, and you have to remember Malfoy syndrome is seen with, it's a autosomal dominant disorder, Malfoy syndrome. Because there is irregularity in the elongation of the bones. There was one mnemonic also like that, Malfoy. For each it was like that. I don't remember right now, but there is a mnemonic for Malfoy. So yeah, then we have a 24-year-old post-transplant patient on multi-drug therapy for multibacillary leprosy, now presents with painful nodules on her forearms. You start her on a single drug regimen. Which of the following is not an adverse effect of this drug? So the options are crystal deposit in the small bowel, ichthyosis on stents and forearm, discoloration of skin, crystal deposit in the renal tubules. So I repeat, it's a 24-year-old post-transplant patient on multi-drug therapy for multibacillary leprosy, now presents with painful nodules on her forearms. You start on a single drug regimen. Which of the following is not an adverse effect of this drug? Crystal deposits, ichthyosis on the skin and forearm, discoloration of skin, or crystal deposit in the renal tubules. So yeah, if you can try this. Basically, it's a case of, if you see in leprosy there is nodules present after any drug. That is ENL. Yeah, ENL. What is ENL? It's painful nodules, and ENL is basically erythema nodulum leprosum. So Basically, lightly drug used in immunocompromised young women is clofazimine, which causes deposition of crystals in the intestinal mucosa, liver, lymph nodes, and spleen, not inner tubules. So the answer here is that is the fourth one is the answer. That is crystal deposit and inner tubules are not seen as a ADR for any drug. Any drug in the sense for ENR conditions. So you can see in liver, lymph node, and spleen, but not inner tubules. You cannot see any crystal deposition. And other options like crystal deposits in small bowel is right. Kyathosis is right, and discoloration of skin is also right. Because you have to remember this. Because if it's a ENL, then you have to think about clofazimine, and clofazimine you have to think about the adverse effects of clofazimine. So crystal deposits are not in renal tubules, it's in lymph node, liver, and spleen. Next we have a patient with chronic lymphedema was found to have a positive DEC provocation test. Which type of biological transmission does the pathogen implicated here undergo? The options are propagative, cyclodevelopmental, cyclopropagative, development. So I repeat, it's a patient with chronic lymphedema was found to have a positive DEC provocation test. So which type of biological transmission does the pathogen implicated here undergo? Propagative, cyclodevelopmental, cyclopropagative, or developmental? So let's basically you have to try this. I will say the answer here is, if anyone can tell, it's a patient with chronic lymphedema and positive DEC provocation test. Basically you have to tell what is the quality of organism for this. If it's a lymphedema, you know it's a filariasis. We all know it's a filariasis because lymphedema it's a filariasis. It will cause the filariasis. So the quality of organism, we also know it's a Bucheria bankruptcy, and if it's a Bucheria bankruptcy, it undergoes cyclodevelopmental transmission. So what is cyclodevelopmental transmission? It's a transmission where the agent undergoes only developmental changes and not multiplication within the vector. So basically it's not multiplication, only developmental changes. So yeah, it's a cyclodevelopmental transmission and Bucheria bankruptcy, which causes lymphatic filariasis. So next we have nivolumab is used as a checkpoint inhibitor of Bucheria bankruptcy is the right answer. Next we have nivolumab is used as a checkpoint inhibitor in options are retinoblastoma, medulloblastoma, pleuropulmonary blastoma, Hodgkin's lymphoma. So I repeat, nivolumab is used as a checkpoint inhibitor of retinoblastoma, medulloblastoma, pleuropulmonary blastoma, or Hodgkin's lymphoma. Anyone wants to try this? Okay, the answer here is answer is D, that is Hodgkin lymphoma. See, nivolumab is used as a checkpoint inhibitor in which condition? That is Hodgkin lymphoma. It blocks the interaction between PD-1 and this ligands. That all you have to remember. But only what are the uses of nivolumab? That is advanced melanoma, NSCLC, that is advanced non-small cell lung cancer, renal cell carcinoma, advanced head and neck cancer, and Hodgkin lymphoma. So you have to remember which is a checkpoint for nivolumab. Next we have, it's a 52-year-old female patient presents with gradual difficulty in breathing for the past 6 months. She is on methotrexate for rheumatoid arthritis. So what is the investigation of choice to confirm a diagnosis? The options are MRI, PET scan, HRCT, and chest X-ray. Basically, it's a 52-year-old female gradual increasing difficulty in breathing for the past 6 months. She is already on methotrexate for rheumatoid arthritis. So what is the investigation of choice to confirm a diagnosis? And the options given here are MRI, PET scan, HRCT, or chest X-ray. So yeah, if anyone wants to answer this, so it's an easy one. See, it's a difficulty in breathing since 6 months, and that too rheumatoid arthritis is present. So yeah. Okay, the answer I will only tell it's HRCT is the right answer, because basically you want diagnosis as an interstitial lung disease, that is ILD. And for ILD, the investigation of choice is HRCT. PET scan you don't do because it's using basically carcinomas, and MRI, chest X-ray we don't use. Confirmatory test is ILD only, interstitial lung disease. For ILDs, yeah, it's confirmatory CT. So, but why we are considering it's an ILD? Anyone can tell? Why not anything else? Because something has to be there. Because see, methotrexate will cause something, because of that only it can cause ILD, because yeah, there is one cause for that. And methotrexate will cause, basically it will cause ILD in long term. That's why we think here ILD is the reason, and that's why we give HRCT, we investigate for that. Next we have a 5-year-old child comes with abdominal distension, palpable mass, and the gross hematuria. A biopsy of the mass shows the following picture: which of the following Painless syndrome is not associated with this tumor? And the options are hypertrophic primary osteoarthropathy, polycythemia, hypercalcemia, bleeding. So anyone can answer this. So it's a 5-year-old child with abdominal distension, palpable mass, gross hematuria is present. Biopsy shows a mass, and they have given one pathological picture, and which of the following paraneoplastic syndrome is not associated with this tumor. Basically they have given triphasic components of, okay, I will only tell, it's a Wilms tumor. Basically they are telling it's a Wilms tumor. So which of the following paraneoplastic syndrome is not associated with this, that is Wilms tumor? Options are hypertrophic primary osteoarthropathy, polycythemia, hypercalcemia, bleeding. This I can guess. At least guess this one. Which of the following paraneoplastic syndrome is not associated with Wilms tumor? Hypertrophic primary osteoarthropathy, polycythemia, hypercalcemia, bleeding. Anyone? Anyone can tell this answer? Okay, the answer here is, that is the A only, that is the hypertrophic primary osteopathy is not a paraneoplastic syndrome of our Wilms tumor, and that's all like polycythemia, hypercalcemia, and bleeding are the part of the paraneoplastics for the Wilms tumor. See, we have hypertension, polycythemia, hypercalcemia, Cushing syndrome, and acquired von Willebrand test, and bleeding also may occur. Okay, so yeah. And what is the triphasic component in Wilms tumor? They have malignant small blue cells, tubular structures, leukocyte paucicellular stroma, and spindle cells. So this you have to remember, and which is not seen here. Okay. Next question we have. 47-year-old woman presents with pain in the right hip during ambulation for the past few months. There is no history of trauma. An X-ray was done, as it is shown below. I will tell what is there. And which of the following most sensitive investigation to confirm the diagnosis? So basically, what do you think? It's a 47-year-old, pain in the right hip during ambulation past few months. History of no history of trauma. An X-ray was done. Basically, in X-ray, what it is showing is it's an avascular necrosis of the femoral head. Now you can tell, if it's an avascular necrosis of the femoral head, what is the investigation of choice? It's MRI, CT, DEXA, or TC bone. Anyone can tell? What is the investigation of choice for avascular necrosis of femoral head? MRI, CT, DEXA, or TC bone scan. Anyone can try this? Okay, the answer here, see, if there is a avascular necrosis, it means the most sensitive investigation will be MRI, because in MRI we can see the surrounding structure, that degenerative changes you can see surrounding the bone. So the most investigation of choice is MRI for a avascular necrosis. Next we have flow cytometric MRI. Yeah, MRI is the right answer. Next we have it's a last question. It's a flow cytometric analysis of 4 patients is given below. So who among the following is suffering from CLL? So basically this I cannot tell which image is question, that's why. Basically they have given a flow cytometric analysis of 4 patients, and who among the following is suffering from CLL. So how will I tell the thing? Okay, I will just tell what is CLL. CLL you know, I don't need to tell. Basically you have to learn that CLL and CLL, CD23 and CD5 is positive, hence the flow cytometry of the patient correctly represents the phenotype of CLL, and the tumor cell also displays pan B cell marker, that is CD19, CD20. Just have to remember what is the CD10, CD20. So yeah, 25 MCQs are over for today. Yeah. Thank you so much for joining.